Hello and welcome to our next episode of Clinical Conversations provided by the Royal College of Physicians Edinburgh Trainees and Members Committee. My name is Bularga and I'm a T&MC member. For this episode of Clinical Conversations, I have the pleasure to speak again to Drs. MacKenzie and Chirwa, who this time will share their experience of the pandemic in Malawi. During our last episode, our guests gave us some important insights into their experience of training and practicing as a doctor in Malawi. Dr. MacKenzie is an infectious disease consultant who trained in Edinburgh, and Dr. Chirwa is a consultant endocrinologist who did medical training in the UK. So welcome both again, and thank you very much for your time. You shared some very valuable experience of practicing medicine in Malawi, and we learned about the current developments in the training system, the challenges that are facing healthcare delivery, but also the progress that has been made over the years. The pandemic has inevitably affected life in Malawi, and particularly delivery of healthcare. And we're very keen to learn about your account of this. So without further ado, I'll just start with some questions. And before we talk about COVID-19, during our previous conversation, we discussed about the healthcare burden in Malawi and the increased prevalence of non-communicable diseases with ongoing high prevalence of infectious diseases. Can you both give us an overview of how things have changed over the years and what has had a major impact on these changes, in your opinion?
Yeah, I'll let Mike start.
Thank you, Anda, for having us back. I think that my colleague, Isaac, has been, practicing in Malawi for longer than I have, but I have been in and out of the region in Zambia and South Africa with kind of similar burden of diseases, really. The major kind of communicable disease of international concern that we really dealt with has been, the HIV, situation, and that's still a big problem in a country like Malawi. There's still patients getting admitted with the opportunistic infections, and they can become sick and they can die. But on the other hand, really has been a tremendous progress with an illness like that, and in a large part. For instance, when I was in Zambia more than a decade ago, treating HIV was an inpatient endeavour. It was looking after people with opportunistic infections, unusual forms of meningitis, and tuberculosis associated with HIV, severe tuberculosis. That has changed now quite a lot with the sort of progress in the forms of treatment that are now available. It's mainly an outpatient endeavour. And there's been an awful lot of effort and multidisciplinary effort put into that. I think at the moment it feels that that's an encouraging thing that we had such a big obstacle. It affected Edinburgh in a particularly severe way. It infected the USA, it infected India and different places, but particularly it affected in this region. I think Isaac and I'm sure will confirm we've seen with our own eyes that there can be progress with these communicable diseases with concerted effort, political will, academic endeavours, and the work of the clinical workforce. Things can really improve. And that's been my major experience coming to Malawi sort of decade after I first visited Zambia. Progress has been made.
What about you, Dr. Chirwa? And I guess my following question would be, do you think this is, it will be linked to antiretroviral therapy, but how that impacted Malawi?
I think there's been a great really change in terms of HIV and TB care, which are a huge burden of not only morbidity, but really a huge mortality in those years, the late 90s up to the early 2000s. And it wasn't a nice thing to be in the hospital wards because they were full. So I remember those days when I was a houseman, there was a section for the Kaposi sarcoma cases. We used to admit TB patients then. We used to give them streptomycin, and that would be full of people. So you go to the surgical unit, you have a lot of Kaposi sarcoma people waiting, dressing of the wounds, and it was, a lot of cryptococcal meningitis. Unfortunately, those days, if somebody come in that state, you knew that, unfortunately, you lose them. But, the way things changed, and there was always not a so nice joke that probably the coffin business was one of the most lucrative business those years. But, with the advent of the antiretrovirals, and I know we're going to discuss this further down the line, and how they got decentralized to be available at every facility, even the smallest of facilities, things just changed. By change, it's a huge change. It's such that, these days, if you see somebody with really full-blown AIDS, you actually wonder. And I can say that most of the junior doctors now, they would rarely see the extent of disease which was there then. So in terms of HIV, there's been a big change. But as you're aware, again, over the same years, now we've seen a huge increase in the non-communicable diseases. I think it's always questionable whether we're looking for them before or we're not, or maybe we're looking for them now, or the numbers have just increased. I think that's another topic altogether. But now we seem to have dealt pretty well with HIV as well as TB. There's some advances, and then we are seeing the non-communicable diseases. But what I can just add, because of the success in the HIV care, there's now some thought, and I know some places they're sort of integrating HIV and NCD care. So centers which are looking at HIV, because there are some centers which are just specific for HIV and related diseases, they're now stretching their arms, and then they are now managing non-communicable diseases. So we're trying to use the same structures and just to up the NCD care.
Very, very interesting. So things have majorly changed. The past 18 months have made a significant impact on many aspects of daily living, and I'm sure healthcare delivery as well. How has the pandemic affected Malawi?
So it goes back to the first wave when it came in. The numbers weren't that huge, but then Malawi is a small country, and we are in one or the other, know each other, or know somebody who knows somebody, that sort of thing. And then when we started hearing the numbers of people dying, it started to scare people. And then we went through that after a couple of months, 2 or 3 months. Then we had a good time like anybody else, and then you had the second wave. And I have to look at studies done, but I can ascertain from my experience that the first two waves, it was predominantly the urban population who were affected. But then with the third wave, which is predominantly Delta strain, we have seen a lot of involvement in the rural areas of the country. It has taken a huge toll in most families. So while by numbers we didn't have anywhere near as high as say countries like South Africa, considering our size and how interrelated we are, a majority of us have been, in a way or the other, been if not infected, but affected by the effects of COVID in the last 18 months.
To add on to what Isaac said, I mean, I think Isaac mentioned the word fear. I think that's something that has certainly come also in waves, really in a way that people have sometimes seen alternated between being fearful of the unknown and having seen news and articles and pictures from other places, and then maybe heard of relatives or friends passing away with this illness. It generated quite a lot of fear, obviously. And then at the same time, Malawi was one of the last countries actually to report a case in the world, one of the very last non-island nations to report a case. And so there was also a little bit, I think, of sort of disbelief as well. In a way, we weren't seeing much, and we were just looking around. And so it was really a kind of a mixture of these two states, I think, amongst people. And then in the rural population, it's difficult to know whether people are aware of this at all, although I think they are now. Well, it's kind of been a roller coaster of emotions and states of belief.
Interesting. So the first confirmed case, as you mentioned, was back in April last year. So did the government institute any changes, like lockdowns? What about personal protective equipment? How did you cope with the spread of the infection?
Malawi was quite early on sort of the onset about having restrictions in terms of air travel. At the start, there were some precautions there, and not so much now. So I think control of a landlocked country, initially that might have had something to do with the fact it's one of the last countries. The other full lockdowns haven't really been possible in Malawi for a variety of reasons. But nevertheless, there have been population level interventions, closures of schools, alterations to the way people do transport, and certainly there's been economic impacts from sort of these things, which are amongst the most difficult things for Malawi will be the economic impact, I'm sure. So we've had sort of a halfway house, not full lockdowns. There's still been some pretty severe effects in terms of economics, in terms of education, and it's still been pretty hard, even though the absolute numbers have not been as high as other countries.
And what about the healthcare system? How have hospitals been coping?
Isaac, what do you think about the country at large?
Yeah. So I think just getting back a bit. So as Mike said, in terms of the general control measures, they had to be legal instruments which were put in place. So the Public Health Act and some changes, amendments were made. And then, of course, we had the public health measures, which, there was very slow uptake to start with. It was predominantly, as I say, in the urban areas, but still remained a big problem in the rural areas. And then we have the issue of clinical care, which we're talking about now. So I think initially there were mainly a few centers which were involved in clinical care in terms of admission of COVID-19 patients, and these were predominantly in the tertiary centers, so where you had a structure put up, either an old structure but which was isolated from the main structure. So like you have a main hospital, and then there was a building away from there that was modified to be a treatment center. So initially they were really just the central hospitals, but with the second and third wave, when the numbers started increasing, so it's almost they are quite right across the country, and that entailed a lot of the training of medical personnel, which was done really very well, physical as well as virtual training. I know beginning just after the second wave and before the beginning of the third wave, if I'm not wrong, WHO experts came and they did the physical training of some of the centers which were involved in large numbers. There was a lot of training, and have been meetings. A lot of meetings and a lot of protocols, audit collecting forms, and so much has been done really when you look over the 10 months and how we started and how things have progressed. There are a lot of guidelines now, how you manage hyperglycemia in COVID, how you manage TKA in COVID, and all those aspects. Now there are guidelines which have been drawn over the 18 months. These are sort of things we didn't have right at the beginning in April last year. So there's been a lot of good training. And now again, in supplies, there's a lot of issues of shortage of supplies. And there have been collaboration with a lot of bilateral donors in terms of setting up oxygen plants and ensure that PPEs are available. I think the investment which has been done really the 18 months in the healthcare driven by COVID, it's huge. So that has happened. But then the collateral damage to that, which I'm sure it's not only for Malawi, but as you could understand that when all focused on COVID care, and to start with, it's important to understand that we don't have a huge number of healthcare workers in the country. So if you have a huge number of people who were involved in managing of these COVID centers, then obviously the other elements were affected. So obviously you'd cut surgical cases, other clinics like the NCD clinics, they'll be affected. In terms of HIV care, so patients whose clinic visits will be every 3 months will be pushed to 6 months and supply them drug for 6 months. So some adjustments were done, but that could also come with collateral damage for other diseases other than COVID. And now some of the things which are being discussed on how do we handle this to avoid in case of a fourth wave, how do we avoid this imbalance in focusing on COVID care and overlooking the other elements?
Yeah, I hadn't been practicing that long in Malawi, but 6 months before the COVID cases started coming here. The essential part of healthcare for me still is people, the human resources, and as Isaac said, they're particularly in certain cadres in really short supply. Isaac in particular as a sort of specialist, but people who work in anything like anesthetics or critical care, those are very rare people indeed. Initially, I think it was a challenge. There were some fears, we said, and it was a challenge to get people to come to the bedside at these emergency treatment units. But people did come. And then the same, I think, in the UK, there were some healthcare workers who contracted and passed on as well, and that's clearly happened in different places in the UK, I know, and it's always sad, but it really is such a scarce, precious resource, experienced healthcare providers that was really keenly felt here. I've not been back to Edinburgh, Scotland, or the UK since this started, but I've seen that there's strain in resources on PPE and all the rest of it, and that happened here for sure. It was very difficult. There wasn't any rapid tests or lateral flow tests to start with. There was PCR, but that was very scarcely available. So suspects were put in sort of temporary places and sometimes would either be recovered or dead by the time the diagnosis was confirmed. So we had those challenges. The major challenge has been oxygen, really, that's a very scarce resource here. And while we've not had the same magnitude of numbers or mortality as what we saw famously in India, in the first and second wave, certainly to a lesser extent, the third wave, these kind of oxygen shortages were causing, in a much smaller scale, people to lose their life where they might have been saved if there was a better oxygen supply. It really stretched the resources to the maximum here. It is interesting because we talked about infectious diseases and TB and these other transmissible diseases, that we would have thought that in a country like Malawi, where these diseases are still common diseases, that there would be maybe more isolation facilities or better design of health facilities with IPC in mind, infection prevention control in mind, and that's actually not the case. There was a lot of modifications and emergency buildings having to spring up because the infrastructure and the architecture wasn't suitable. I suspect that some of these are very familiar challenges to the people who've been working in COVID in the UK and in the NHS. But there was particular peculiarities in Malawi, which make it slightly different.
Yeah. And interesting that you mentioned, particularly in the first wave, we also observed that patients avoiding to come into hospital with a emergency presentation. And there was public health campaigns at the time to advise people to come in if they had symptoms of, say, myocardial infarction or a stroke. And you said there was something similar as well you found last year, that kind of fear within the population.
That was present, and it's probably during each wave. We've just passed the third wave. I think people maybe do put off still. Those who are well informed about COVID probably do still put off things.
So you were saying that the country is now at the end of the third wave. How is the pandemic affecting Malawi at the moment? Are there still restrictions in place, or life is back to some form of normal?
So yes, there were restrictions which were lifted, I think a week and a few days ago, like how many numbers of people could meet in an enclosed environment, etc. But things like the mask, that still stands. You have to put a mask on. I'm just thinking in terms of change of life. Again, it's really individual based because some people really didn't follow measures or laws. So in some centers, people could still do their own things. But I think what this has done is it has made those who have knowledge and lived in fear when the numbers were high to sort of relax now and go and see their friends, because I know some people who are not going out to see their friends. I know some places of work, people were basically working from home since March last year. Some people are now going back to work, some in reduced hours, others in like a shift system or rotation system. So the things have opened up. It really feels a bit normish than how it was 2 months ago when really everyone was in fear. Things have changed a lot, and now with the sun, you can take a walk and run and enjoy the sun without much fear as you had a month or so ago.
I think both of us, Isaac, have come from separate planning and trainings about COVID this afternoon, both Ministry of Health things, I think, and basically that we're diving right into planning again, which I think is a change from when previous waves went over. There was a sort of just a feeling of relax and then it's over, but now we're really getting to the stage where there's a widespread understanding that we're going to be trying to do things that we weren't able to do during the height of the kind of community transmission. But planning for the future now, I think that's pretty intense still, which is good, in terms of how we're adapting to this new situation that we have. There is adaptation there.
Thank you very much, both, for those important insights, both on how healthcare has been affected in the last 18 months, but also generally the country, the population of Malawi has been affected by the pandemic. I would like to talk a bit about managing the infection, but also vaccination programs. So to start with, would you be able to give us a run through how a COVID-19 patient admitted to hospital is managed?
Yeah, myself, I've only managed them in Malawi, actually, COVID-19, although in a previous life as a trainee in Edinburgh, we used to test for things like MERS coronavirus. Fortunately, there wasn't any cases. A lot of the basics will be the same as would be in Edinburgh, say. we have to sort of identify suspects, and there has to be some screening for suspects. Obviously, there's not really anything like NHS 24 or any kind of advanced screening, and even sort of a lot of facilities won't have a telephone line to give advance warning of their symptoms. So really that has to be done the front gate of a facility or the front door. In fact, that's a bit easier said than done because there can be quite large queues to get into facilities early in the morning. So introducing the screening and the early recognition and then was an important sort of endeavour, which is probably still not perfectly done, but it is better than it was. In terms of managing, I've been fortunate to work in places where there are oxygen supply, which is pretty reliable. Usually our severe cases are hypoxic. The availability of pulse oximeters has gone up dramatically, fortunately, but initially it would sometimes just be a clinical assessment with pulse oximeters being in shorter supply. The supportive care at a ward level is broadly similar, although quite a lot of facilities rely on having cylinders filled and being carried back and forth to the patients, which is quite a physical operation, which requires, a lot of effort and planning as well. I think we were, like everyone else, watching keenly and overjoyed when the sort of recovery trial, found that dexamethasone was an effective treatment that could have an impact on mortality. Steroids are commonly available, I think, pretty much worldwide, including Malawi, and dexamethasone has been. And so we've been able to give that kind of, disease-modifying drug pretty much to everyone who needs it. I think where it starts to separate a little bit is maybe now we read and we see that there are, biological treatments and monoclonal antibodies which can also impact mortality, and it's very rare for someone to access that here. I think I've had the odd patient who's been able to go to Kenya to access those kind of agents, but on the continent it's exceedingly rare. So I think in this part of the world, pretty grateful that the commonly available cheap and drugs that are being repurposed possibly for COVID-19, at least these are being studied. If it were only a case of studying expensive new medicines, then it would be quite difficult to access those. It also diverges when you get to critical patients, because critical care is critically low in Malawi and several other countries around us. Some of the institutions were able to push to CPAP and sometimes high flow nasal oxygen, but it's quite difficult to get the equipment for that even. So when we do see from the UK or other countries the very full critical care units and mechanical ventilators, that doesn't really exist. Those large true ICUs that have done an awful lot of good work in the UK, for instance.
Yeah, and I think just to add on what Mike has said, he spoke about oxygen and the use of oxygen cylinders. A huge chunk of facilities don't have the oxygen plant, so basically the source of oxygen is oxygen cylinders, and it's a big endeavor. It requires a lot of planning and a lot of physical work, moving cylinders from one place to the other. And when the numbers were high, the biggest problem was running out of oxygen. In most centers, there's a lot of multidisciplinary team. There's a lot of physiotherapists who are involved, who see the patients along with the doctors during the ward rounds and help with the physio breathing exercises. So in terms of the general ward care, as I said, a lot of protocols have been written, but once we would have to escalate to high-level care, then we're only limited to our 4 central hospitals, because those are the ones who have ability to give respiratory support beyond something as simple as CPAP. I'm not sure in terms of mortality cases how much would have been different if we had the ability to escalate care to high level care than what's happening now. That's always an area to improve on. The use of dexamethasone has made a big difference, and it has really helped a lot. It's really available throughout the country. It is a big blessing that such a cheap drug would help the outcome of the disease.
Indeed, we've all been happy and really excited about the recovery trial results last year. What about testing? So you did mention at the beginning, first wave, there wasn't access to lateral flow tests, PCR tests. What about now? Do you have wide access to these tests? Do you rely on them as a screening kind of method?
At CHISO, in our reference lab in the Long Way, they're sequencing, like many other countries, but they're sequencing COVID-19 to figure out where the predominant strains are now. And I think Isaac can correct me if I'm wrong, but historically there's been a huge lag in terms of medical technologies and drugs and so forth reaching somewhere like Malawi. Malawi has these sort of cutting edge technologies now within a few months of other countries. PCR, as a diagnostic method is a fantastic technology for Africa because it doesn't have the same level of technical support required for old-fashioned microbiology and virology. So, and it's become readily available, and the rapid tests, as you say, in the sort of as a first line screening method have become available, and so have self-testing methods are starting to come as well. So these things have come pretty quickly, but it wasn't quickly enough in the first and the start of the second wave. It's pretty difficult without these diagnostic methods to sort of figure out which areas patients should go to and how to separate people appropriately. The other thing that might be different in terms of patient care and working in a COVID ward in Malawi is that the patients' relatives or friends, they're known really as guardians here, play quite a big part in the whole process of being unwell and being in hospital. It's quite normal for patients to have many visitors, for family members to help with the care, to sort of compensate a bit for lower nursing numbers. In some of the UK, and you can correct me if I'm wrong, is that there was kind of a restrictive policy in the UK in terms of who was allowed in hospital and so forth. Quite often in facilities, we don't have that level of security or control of the environment. So there would be patient relatives coming in. We'd have to try and explain why they shouldn't go to see them, what's wrong, what this new disease is. It caused quite a lot of angst, confusion, and when it came to transferring patients from a regular ward to a COVID ward or to another hospital, there was a lot of fear about that. So there was a huge amount of communication and interface with relatives. I don't know, Isaac, was that your experience?
Yes, that was a big part of the care, to let the relatives understand that they can't be part of this in this case. However, having said that, there have been protocols drawn for allowing one guardian. Some of the early centers which tried this one is one of the faith-based hospital in Lilongwe, Partners in Hope. So they did that successfully, I think, during the first and second wave. And it sort of eases tension because, there's a belief you're admitted to a COVID care unit and then you die. And the families are basically in limbo. So if there's a relation in there who sort of communicates with them, sometimes it helps to allay the fears. Partners did it pretty well. So there are basically guidelines being drawn to try to roll it nationally. I know that it wasn't fully done during the third wave, but they're still looking into strict measures, how so the guardian will be tested when they're going in, so they don't come out, they stay there, they communicate with the people and do everything. So, and then I think they sort of sign something and follow a particular protocol. Yes, we had to accommodate the cultural aspect of how basically all diseases are managed to avoid stigmatizing COVID patients. So I'm sure that should it happen that we have another wave soon, most centers, I think, it depends how a center is set up. So some centers might follow the guardian policies which have been set up for the facilities. But yeah, that was another major aspect of patient care, really, in our setting.
One of the interfaces between hospitals and communities, of course, when somebody dies, passes away, and there are certain changes that had to occur to the normal funeral practices, which sort of are common in the country. And there was memorials and different services that had to be delayed and done in a different way. Again, that will be true in UK and in Edinburgh and Scotland and different parts of the world. But I think these ceremonies are very, very important in Malawi. So I think that had to be explained and people had to come to terms with that. And I don't know just quite how disruptive or how easy that was for people to change those ways. What was your experience, Isaac?
In urban areas, people came to understand, and the funerals were being conducted in a different way altogether. The numbers were fewer and the time people spent with the families. So it changed. It changed because people they're knowledgeable to an extent, and they saw what was happening. Not the case in most of the rural areas, as far as I know.
Yeah. So you're describing basically adapting to this restrictions, changes, and also the cultural aspects of that, of leaving in Malawi. What about the vaccination program? So, as we said, the last year we've seen some incredible scientific advances, and that's been the introduction of the vaccines. When did this start in Malawi, and how has it been delivered? What proportion of the population is vaccinated, and what are plans at the moment?
Yes, I think we started in April or June with the AstraZeneca from the India Serum Center. Then we got there was a delay in getting our second jab, but we did. So initially we had the AstraZeneca from India, and then we had some further donations, I think, from the UK, the Johnson's and Johnson's, and I think soon we're going to get the Pfizer. The vaccines, yes, they've been in, but the uptake is very low. I think as of today, probably, I think it's 180,000 totally vaccinated. In terms of the proportion of the population eligible to get the vaccine, it's very small. The 400 is the total fully vaccinated. So the number, first dose about 500,000, the second dose, those full dose of J&J, 200-something thousand. But if you compute all as fully vaccinated, then it's less than 500,000 for a population of 18 million. So you could probably stay eligible for vaccination to probably 9 million or 8. So we are still quite far. And I think a lot of factors come into play. I'm not sure if it's just vaccine availability, because we have vaccines, but there's still not the numbers taking it up.
So is that a problem with the population engaging, or is it the delivery of the vaccine that's affected?
Population engaging, really. There are some people of their beliefs, just like anywhere in the world. And I think it's a question of education, and try to disseminate the information to allay the fears. It's not only the rural population, you also see the urban population, quite a significant number of people haven't been vaccinated. So it's maybe how the information has been packaged and what fears people have over the vaccine. It's not just availability. So some people say, no, we can try to reach out to the rural areas, but you can take the vaccine there. But if the people are not mentally prepared to get it, I don't think that will make a difference. And I don't think the argument is personally is entirely true. So we need to inform people more, persistence, and probably bring in new techniques of how to inform people and see how we can reach people, but by various ways. You use the community leaders, you use the church leaders, you use the chiefs, and try to bring in influential people and then see how it works. I don't think it's purely structural reasons. I doubt that.
Yeah, what I would say is that Malawi, we talked about the ART program, antiretroviral therapy programs, and there's big success with ongoing challenges, but big success. And another really big public health success in Malawi is the sort of pediatric vaccination programs. They've been really important, and countries like Malawi have helped to reach, Millennium Development Goals, because they went from low coverage, vaccine coverage, measles and the like, to very high coverage. So it's not really like Malawi is, I don't think, against vaccines, but kind of negative stories seem to travel faster than positive stories. I don't know what you think, Isaac. People do have smartphones here, certainly urban people and people who have kind of employment, and they see videos on WhatsApp, which were, made in other countries. And I think whoever makes them they have another target audience in mind, I think, but they come over here. And so there's a lot of this misinformation and fake stories. And it just creates doubt and fear, I think. We're fighting that battle here. I know they're fighting it everywhere, really. There seems to be quite a high penetrance of these kind of negative messages. But, there's an interesting story, Isaac. I got told that in the village close to where I am, the local chief, when the AstraZeneca vaccination became available, they didn't rush to it, but they sent 2 of his chosen people from his area to have the vaccination. And then he observed them to see what happened. It's a very small kind of study, but I thought this kind of methodology was quite sound, to have that, slight caution about something which is new, You can't wholly be critical about people being a little bit cautious about new things. There have been problems in this region, real problems about clinical trials being done and controversies in the past. So difficult to be too critical. It's just a problem that needs to be engaged with. Obviously, false information needs to be, I think, combated with good messaging from using the people that you've described who are trusted people.
Certainly, that's, that issue, I think, has been everywhere in the world. Thank you very much. Those are very interesting insights. So the vaccination program is continuing at the moment.
It's ongoing, yeah.
But the future is uncertain. I don't know. It's a big challenge. I think we see pledges, and I think vaccine doses are one thing, but I suspect that there will need to be, vaccination, and they talk about actually having people with vaccine-induced immunity. It's human resources, it's communication, it's public messaging, it's engagement, just getting transport to areas. There's a lot of logistics. So I think the cold chain, again, there's been, is pretty good now. It needs to be expanded, but it's there. There's a lot of what people would think of as softer things, communication and education and public engagement. I think that there's a lot that needs to be done there. But I think they can do it because we talked at the start about HIV, and we came across the same issues about people saying it didn't exist, that antiretroviral therapy was poison. These things happened in the region, at least, certainly in South Africa. And eventually people came to what we believe is the right conclusions. But the treatment is really overall a very, very, very good thing. Again, that gives us a little bit of encouragement that we can convince people. But it's just really, can we convince people quickly enough to make an impact in a good time? And I don't know about that.
Well, we hope that things continue to improve. So thank you very much to Dr. Chirwa and Dr. MacKenzie. We are chatting again, doing a quick update on the progress and developments of the pandemic and also the vaccination program in Malawi since we last spoke in September. So welcome both again, and thank you for your time. I was wondering if you could give us an update on how are things developing in Malawi over the last few months.
So, vaccine uptake is still quite low nationally. There is a significant increase in the urban areas, but it still remains quite low in the rural areas. If my memory is correct, I think we're probably around 6-7% this month of vaccine uptake. However, there's been a move. The government has announced that now 12 to 18 wards will also get vaccines, the Pfizer vaccine, and we're yet to hear how this program will roll out. Again, there's issue of booster vaccine. I think that was discussed again, but currently the stance is let's try to vaccinate as many people as possible before we talk of booster vaccines. So I think the issue of a booster vaccine will probably be looked into again, maybe next year, depending on how things unfold. So vaccines uptake is still quite low. And obviously then that brings in the concern of what the impact might be with Omicron. So yes, officially we're in a fourth wave now. Started a few weeks ago. Numbers going up. I think this week, Sunday or Monday, the positivity rate was about 14%. But currently, really, we are not seeing the level of admissions we're seeing in the third wave. In terms of how much of our cases are Omicron, that I would not say, but we know that officially we had Omicron cases. We're just told these were samples which were taken between 11th of November and 2nd of December, and sequencing was done locally. So we know that, yes, there is Omicron, but we haven't had any results of further sequencing. But currently, really, yes, we are seeing cases every day, but none are worrying to require admission. So we keep fingers crossed that it remains that way.
Okay. Yes, and Isaac, really nice to talk again. I think at the moment we're at an uncertain moment still. What I've seen in Malawi is that we have some people who are very, very enthusiastic to get vaccines, and you get a lot of inquiries about where to get a vaccine, where to get a particular vaccine, when can a second or additional third dose be given. And that tends to be, as Isaac said, from the kind of people who are living in urban areas who one might assume really have very high level of education and access to lots of different information sources, whether it be media, internet, or even speaking to people who may be healthcare professionals or have some level of knowledge. And then we sort of contrast that again with the kind of national outlook, where the percentage of people who've been vaccinated is very low. And I guess that may well tie in with the rurality of Malawi, that around 80% of the country is the rural population. And often that means less exposure to, accurate or what we'd say is sort of quality checked sources of information. We think that leaves the country vulnerable to the different variants, including the new variant, where it seems at the moment to be very important to be really fully vaccinated in the old terminology with, say, 2 doses of AstraZeneca, but maybe even to have an additional dose Malawi is still vulnerable to coronavirus, to COVID-19, and I think we're still uncertain in terms of we always look to South Africa in this region to see what's going to happen, and I think the whole world is now looking at South Africa to see what's going to happen. We're talking now on Monday, the 14th of December, 2021. We hear that there are less admissions in hospital at the moment. We hear that there are less deaths than previous waves. But I think maybe it still will be a week or two before we can truly judge that. So really, I think all of us who work in the health kind of sector are really tuned in to what's going on in South Africa and the region. And I think the whole world is as well.
Yeah, certainly right. So thank you for alluding to that. As you say, the Omicron variant, which has been classed as a variant of concern, has been first detected at the end of November in specimens in Botswana and South Africa. And indeed, the whole world has been awaiting cautiously information from that part of the world to see how things are developing. So how are things developing, particularly in Malawi? You're saying you've detected a few cases. You haven't yet seen or are waiting to see the effects of that on hospitalization, healthcare resources. What are your predictions?
As Mike has said, I think most of us are watching closely what's happening in South Africa. What we expect is that we're probably going to have bigger numbers than the third wave, because we think that it's predominantly the Omicron. So far, what we know is that the transmissibility is very high. So therefore, we expect high numbers, but we're hoping that the high numbers won't translate into choking of the health sector, that then will require more admissions, more ventilator support, things like those. So it's just to watch closely, but preparations on the ground, and each teams and each center is looking at, if need arises, how can we escalate, how many people we can take in. So there are preparations on the ground taking place, but keeping eyes and ears close on the ground, especially watching South Africa.
As Isaac said, there has been preparations, whether it be dealing with Delta variant or the new variant. Preparations have continued. There's been quite a lot of effort into nationwide training, including the rural treatment centres. So we would hope that part at least is strengthened. If the vaccine has not yet been quite carried around the country, the uptake has been lower, we would hope that the healthcare workers are better prepared than ever before for the COVID-19 wave. And when I kind of reflect on that, I think that it's another example, I think, of having just generally a strong healthcare system. The sort of bottom line would be that that's what will help someone who becomes sick with COVID-19, if they become a severe or critical case, is that they have a kind of hospital to go to which can, help them with oxygen, with the treatment, such as the standard of care here. And there's been different things in the, I guess, debates or investigations to do with the more sophisticated monoclonal antibody style treatments for COVID-19 and whether they'll work with the new variant. In the, in the African region, we're looking still at the same kind of treatments: oxygen, CPAP, which has been introduced, steroids, and good general care and supportive care with infection prevention control. Those things, I think, have been strengthened, and in that sense, we hope that Malawi will be better prepared for this fourth wave, which has just clearly been a small uptake in the last few days. So we hope and we pray for that we are better prepared, but it remains to be seen.
Thank you. Thank you very much for giving us that live overview and update. And thank you again for your time, and wish you all the very best.